Happy New Year, everyone. Thank you for joining us for the Department of OBGYN's Town Hall discussion on the COVID vaccine and pregnancy. My name is Liz Howell, and I am the chair of the Department of OBGYN. The COVID pandemic has taken a tremendous toll on all of our communities, especially among Black and Brown individuals. We are hopeful that the COVID vaccine will help us turn the corner and put this pandemic behind us. The purpose of our discussion today is to provide education on the COVID vaccine in the setting of pregnancy and to answer many of the questions that you have submitted. I just wanted to make sure that you all were aware that we received a large number of questions. We will aim to address the majority of topics that were brought up, but we will not have the opportunity to answer every question submitted. So we're going to start, because of our, we're going to just shift around our program a little bit, and we're going to start today with two members of our faculty who are going to explain how the vaccine works, the benefits and the risks during pregnancy, recommendations by our professional organizations, and share some thoughts on decision making. Next, we're going to be joined by our CMO of our health system to talk a little bit about the vaccine rollout and some specific, address some specific issues around pregnant healthcare workers. And then we'll hear from one physician and one nurse about their decision making with regards to the COVID vaccine. We will end by having a question and answer forum where we will address many of the questions, and we'll be joined by our division chiefs from General OBGYN, Dr. Khalid, and for REI, Dr. Gracia. So I'm going to start by introducing now our two faculty members who are going to be sharing their expertise with us. First, we're going to hear from Dr. Michal Elovitz, who's professor and vice chair of translational research, and she's director of the Maternal Child Health Research Center here in our department. And then next, we're going to hear from Dr. Sindju Srinivas. She's professor and director of Obstetrics, vice chair of quality and safety, and she's the physician lead for the Women's Health Service line. So we'll turn it over now to Dr. Elovitz.
So here we go. So welcome everyone. We greatly apologize for the inconvenience. There's a lot of you on the call, and we know that we've received a lot of questions from everyone. I'm going to do my hopefully under 15 minutes to address a lot of your concerns and those that we've been reached out both in a group and individually. I do want to thank Dr. Howell for her commitment and advocacy to pregnant and lactating individuals in regard to the whole COVID pandemic and to the outroll of the COVID vaccine. So as background, and I apologize, I didn't actually hear Dr. Howell. I've worked for 2 decades at the bench to the bedside in maternal fetal conditions, pathophysiology, physiology, and all sorts of immune responses in both the maternal and the fetal dyad. So from that lens is how I'm going to present to you today this work. I've also been actively involved in the COVID clinical trials group at Penn and have funding from NIH to do COVID research in pregnancy. So as you all know, COVID-19 is a pandemic of unknown proportions in over a century. Just to bring home the point to everyone on this call, and I probably don't need to, is the number of deaths in the United States and in Pennsylvania and the number affected. And contrary to a lot of what is in lay press, COVID-19 is most definitely creates more morbidity and mortality than the seasonal flu. These numbers are from just yesterday. So very concerning. Clarissa, I'm getting text. You're in the video if you want to close your video. So these are the hospitalizations for COVID since March 3rd of 2020. And you'll see that we are entering 3rd, 4th, 5th wave, whatever we might have. I'm stopping again. Mike, they keep seeing Clarissa, not me in the video. So if you could fix that, that'd probably be helpful for the audience. So with these 2nd, 3rd, and 4th wave that we're seeing, the question I think that is on a lot of people's mind is, can vaccines actually stop this trend? Can they stop the increase in morbidity and mortality from this growing COVID pandemic? So this is taken from the Pfizer data, which is one of the vaccines we're going to talk today. This is the placebo arm. What you see here on this red line is the number of cumulative cases of COVID-19 days after these individuals received the placebo dose of the vaccine. And as you can see, there's an increasing prevalence of COVID-19 infection in those individuals who do not receive the mRNA vaccine, specifically the Pfizer one. You'll see in those who received a vaccine that there was a dramatic, almost unseen impact of the vaccine in reducing COVID-19 infection. So this is really dramatic and reflects the efficacy of this COVID-19 vaccine. So what do we know about the efficacy? And we don't know if it's efficacious or not until we actually apply it in real world conditions. So what we know is the efficacy. So both the Pfizer and the Moderna vaccine, which are mRNA vaccines, which I'll speak to in a minute, we're not speaking about any other vaccines right now, just those two, are able to protect with about 90 to 95% efficacy. That's pretty powerful vaccines. You do, from the clinical trials that were done, need both doses to be fully effective. We don't know whether being vaccinated prevents about passing viruses to other. So I've been asked a lot of questions about this. So if I'm vaccinated and I'm exposed to the virus, it may be possible, we don't know, that I could have those viral particles on me or in me, and that in a situation, if I'm not wearing a mask, I might still be able to transmit it. So the Moderna vaccine, which came out, shows there might be an effect against transmission, but we don't have hard data yet, and the Pfizer didn't study it. That means if we get vaccinated, or when people get vaccinated, they still need to wear masks and practice hygiene and social distancing. So I want to talk just for a moment about vaccine safety in non-pregnant individuals. So according to the FDA, the most common side effects in participants, and this is from that phase 3 trial for both Pfizer and Moderna, the side effects are about the same. You can see hopefully on the left side of your screen. So injection site pain, fatigue, headache, muscle pain, chills, joint pain, and fever. If you kind of are weighing, which this all comes down to risk assessment for every individual, vaccine risk versus benefit, I would put forth that for most individuals, the benefit of the vaccine and associated reduced risk of acquiring COVID-19 far outweighs any of the risk from the vaccine itself. What we don't know is if this side effect profile that you're looking at on the screen is actually the same in pregnant individuals. So because pregnant and lactating individuals were not included in any of the clinical trials, some people make the assumption that the side effects are the same, and they may very well be, but we actually don't have that data to inform you of that. So what did the FDA say? So the FDA gave what's called an EUA, or an emergency use authorization, for Moderna and the Pfizer vaccine. Notably, a lot of the questions that we got for this call were, how does that apply to children and subsequently to fetuses? So I'm just going to take children for a moment. So what the FDA granted was an EUA for the Moderna for anyone 18 or older, because that is who was in their clinical trial, and the Pfizer vaccine for anyone who was 16 and older. So the studies, there's an ongoing study from 12 to 16-year-olds. There are additional studies happening, but this is not approved for the pediatric population. Both trials excluded pregnant individuals. So if you were pregnant, you are not able to enroll in either the Moderna or the Pfizer clinical trial. There is not enough data at all to make any inferences of women. It is unclear how they got pregnant or related to the vaccine, and there's absolutely no data captured on what happened or not during their pregnancy or fetal outcome. So while there are these 35 women, we should not take these women to indicate any kind of outcome, good or bad, from this trial. So when the companies want to go to a trial in pregnant women or pregnant or lactating women, there's the requirement for what's called DART data, or reproductive toxicology data. So Pfizer has not submitted their data yet to the FDA. Moderna did submit data on December 4th to the FDA. It was a study done in rats, and they used a dose of 100 to administer in rats and did not see any perinatal or postnatal reproductive toxicity. Now, what that means is that there was no what we call teratogenicity. Based on the mRNA vaccine biology, which I'm going to show you in a minute, we wouldn't have expected any teratogenic effect because the vaccine itself does not get into the cell, into the nucleus of the cell, and can't change DNA. And I'm going to go a little more into that. What the DART data does not tell us is whether any active part of the vaccine or the parts of the vaccine traffic to the placenta or are able to go from the placenta to the fetus. The American College of Obstetrics and Gynecology and the Society of Maternal Fetal Medicine both have stated in written documents that those who are pregnant or breastfeeding should be given full access to the vaccine. So to be clear, there's not a recommendation to take or not to take. The recommendation is that it can be offered and there should be individual risk assessments with the individual's provider. The vaccine development. I want to spend one slide on this because there's a lot of misconceptions out there. So maybe you've seen a table similar to this that really touts the amazing scientific discovery of going from sequencing the SARS-CoV-2 virus to actually phase 1 vaccination on December 11th. So it is very impressive road, but it must be noted that just sequencing the vaccine itself in January would not have not made an impact if we didn't already have the mRNA technology. So very quickly, the mRNA technology that enabled these vaccines is not new at all. So studies in animals looking at how to change the mRNA from creating an immune response to being more of to delivering a message but not inducing the immune response was done in the 1990s. From Penn, doctors Karakiko and Wiseman published their results in Immunity, looking at how they were able to modify the mRNA so that it did not induce the same immune response. So just to drive home the point that while there has been a very rapid development and trials of this vaccine, the technology used for this vaccine is not new. So I'm going to use the schematic that you see on the left side part of your slide for the lipid nanoparticles. So that's what's in this mRNA vaccine. So hopefully you can see on the slide, this is the outer layer, this is a lipid component, and inside is the mRNA that is the code for the spike protein. So this is in the vaccine that gets injected into an individual. So it's very important, a few things to note. So this is the sequence of the SARS-CoV-2 spike protein that you've heard about. So this is the part of the virus that triggers the immune response. But this mRNA sequence is not a live virus. It is literally the code for that virus. So it tricks our bodies into seeing this and creating the spike protein without ever having virus. What is important to note, as I've noted before, is that this mRNA cannot get inside the nucleus of a cell. So it does not change the DNA of a person, of an egg, or a sperm. So it was asked, and I know some may not find this that interesting, but for those who asked, this is the size of the LNP-MRNA, and it has a neutral charge. And this becomes important when we talk about its ability to cross the placenta or not. So what kind of happens in our bodies to this? So again, here's your lipid nanoparticle. It's injected. And then what happens in any of us is our body reads that code and actually creates a spike protein. Again, no virus. It creates a part of the protein that the virus would make, but without having the virus in our body. So once our body sees the spike protein, it recognizes it as foreign and says, what is this? And so the body's natural immune response then creates antibodies to the spike protein. Why this helps us is that then we're walking around after we get vaccinated and get exposed to the actual virus. These antibodies recognize it and will prevent us from getting infection. And that is how this whole mRNA vaccine works. So now what about pregnant individuals? So what do we know about the risk of COVID-19 while you're pregnant? So we know in general, there's an increase in perinatal morbidity and mortality whenever a pregnant woman is critically ill. So respiratory illness, especially moderate or severe respiratory illness from whatever cause in pregnancy, is known to be associated with an increase in perinatal morbidity and mortality. SARS-CoV-2 or COVID-19 infection is no exception. What we do also know is about 1 to 3 per 1,000 pregnant women with COVID-19 will develop severe disease. Compared with those that are not pregnant, but age matched, COVID-19 infected people are more likely to need ICU care, or more likely to require a breathing tube or mechanical ventilation, and more likely to need advanced life support or ECMO. There's also a report of a 1-point-fold increased risk of death from COVID-19. I do want to make the caveat that this is from CDC data that was released in December of 2020. It came from a very large database, of which only 35% of that database had actual pregnancy data. So we don't know how biased this data is or not. This is the best data we have to date regarding the morbidity and mortality from COVID-19 in pregnant women compared to age-matched individuals. So I was asked this a lot in the questions. What is the risk of maternal COVID-19 infection to the fetus? So when the pandemic first started in March, there was concerns that SARS-CoV-2 could infect the placenta and the fetus. What we know now, and from a very eloquent study published from a colleague of ours out of Mass General, is that COVID-19 infection of the fetus is actually very rare, even in women with moderate or severe disease. There are more sophisticated studies that I won't go into today showing how the placenta, actually with its natural protective effects, is able to prevent fetal infection with SARS-CoV-2. So in general, we are much more concerned about maternal morbidity and mortality from COVID-19 than we are about transmitting that virus to the fetus, which again, we believe is a very rare event. There is insufficient data at this time, despite what is happening in the lay press, to know whether general maternal COVID infection, all comers, mild and moderate, are associated with adverse pregnancy outcomes such as preeclampsia, preterm birth, or stillbirth. What about vaccines in pregnant individuals? As many of you know, we give vaccines in pregnancy all the time. There are those, if you look at this chart, that are recommended in green, contraindicated in this kind of light pink color, and some are indicated as noted in yellow. So two important points, two important vaccines. So flu, as many of you know, we recommend the flu vaccine to pregnant and lactating individuals seasonally. We also now, a few years ago, started recommending the tetanus, diphtheria, and pertussis vaccine, or the DPT, in the third trimester of pregnancy. This vaccine is now given to pregnant individuals not to protect mom, but to enable protection of the neonate against early pertussis. So how does that work? So mom gets vaccinated, and this is to influenza or pertussis or whooping cough. And then, as I showed you on the last slide, a mother makes the antibodies to that virus. When she makes the antibodies, they are able to cross, specifically what's called IgG antibodies, are able to cross from the mom to the fetus. And then that provides neonatal protection against that virus. What we don't know, despite that we've used vaccines for years in pregnancy with safe administration, is that there is no prior use of an mRNA vaccine in pregnant patients. For that matter, there's no prior use in non-pregnant patients. So this is what happens or not to COVID-19. So I was asked this as well, and I want to address this. So as I mentioned before, this is a lipid nanoparticle with mRNA in it. This is the size and the charge. What we know happens, and this is non-pregnant individuals, that when we get an intramuscular injection of this lipid nanoparticle, that within 1 to 2 hours, it is rapidly distributed around the body so that our immune response can take it in and respond as it. So what happens in pregnancy? Do we get this rapid distribution? And the fact is we don't really know. One might assume that knowing what we know about other vaccines, that's similar to a non-pregnant individual, there would be no reason why the LNP-MRNA would not be rapidly distributed in a pregnant woman as well. There's a couple of things we don't know. Could the appropriate response to the vaccine, which as many of you heard, especially after the second dose, there may be fever and fatigue, if that happens in a mother, in a pregnant individual, could that response that is appropriate for the vaccine actually cause harm to the fetus? The second question that I know so many of you want to know the answer to is, does this lipid nanoparticle with mRNA actually able to cross the placenta? So let's tackle that one first. So this is I'm not going to go through details of the slide, but this is basically showing you a maternal blood cell, the placenta, and then a fetal blood cell. This is taken from a review about nanoparticles and the ability for them to cross the placenta. So this is a silicon nanoparticle that is about at 70 nanomicrons. And this nanoparticle actually can cross the placenta. But what's important to know about this is it's not a lipid nanoparticle, and it was designed specifically to cross the placenta. So what do we know about nanoparticles in general? And there's a whole host of papers that have looked at nanoparticles and the ability Two are not crossed the placenta. And it is very much dependent on that outer layer that I've showed you and the charge and size of the nanoparticle. In all of this research, what unfortunately I have to tell you is that lipid nanoparticles have not been studied at all. There is no data on the ability of a lipid outer layer to be able to cross from the maternal circulation into the placenta. So then what are the possibilities? I've been asked individually and by many of you to address this. So here's possibility number one. The possibility is that the mother is administered this lipid nanoparticle. She makes antibodies as we would want her to, and those antibodies, similar to what we see with influenza and DPT, cross the placenta to the fetus and provide protection. This would be an excellent outcome. So this is possibility number one. Possibility number two, mother receives the lipid nanoparticle. It goes and it sits in the placenta, but it doesn't reach the fetus. If the lipid nanoparticle sits in the placenta and doesn't reach the placenta, then doesn't reach the fetus, and it doesn't have an impact on the placenta, then there's no consequences. However, so the lipid nanoparticle, the lipid itself triggers to a specific receptor that's called EPO-E that is on the placenta, and so there is the possibility that the lipid nanoparticle itself could induce an inflammatory or a cytokine response in the placenta. That could be associated with a theoretical risk of harm. Possibility number three. The mRNA, the LNP-MRNA, again, is given to the mother. It crosses from the placenta into the fetus. The fetus then does what adults do, and its immune system responds to that LNP-MRNA and actually makes the spike protein. The fetus with a competent immune system notes this foreign protein and itself makes an antibody response. So this would be unique, and it would be the ability of a fetal antibody response that we've actually never done before, which would be in some ways a really amazing scientific ability to offer fetal antibody protection. We don't know that this happens, it's just a theory. However, if the fetus, similar to teens and adults, makes this appropriate immune response with the antibody, similar to how many of us will experience some fever or fatigue with the vaccine, will that happen in a fetus? Will the fetus, along with engendering an antibody response, respond with having an inflammatory response? If this happens, and again, we're a lot of ifs at this point, if the fetal immune response generates potentially harmful immune mediators, it is possible that that could cause fetal harm. It is not known. So many of you asked about the trimester. There is insufficient data about whether increase these theoretical risks of a fetal immune response. So to be clear, and this is work that we've done in my laboratory for 2 decades, the concern with an immune response in the fetus or the placenta is that we have pretty solid research demonstrating that these type of responses, whether cytokine or chemokine or other immune mediators, can cause harm to placental function, the fetus, and or the fetal brain. Again, we do not know if the LNP-mRNA crosses the placenta, and if it does, whether the fetus will respond to it. So lactating individuals. This is what is assumed, that immunogenicity to the mRNA vaccine should be similar in lactating individuals as to non-lactating, and they should develop protective antibodies to COVID-19 infections. Again, these individuals were not included in the clinical trial. What is known? That maternal protective antibodies definitely cross into breast milk. The assumption is that mRNA vaccines administered to lactating individuals should induce maternal IgG antibodies to the spike protein, cross into breast milk, and similar to other vaccines, provide neonatal protection. I've been asked a lot if the spike protein generated in the mom can cross into the breast milk. So again, we don't know. If it can, though, it will end up in the neonatal stomach, and it, to many of us, feel, and this is just expert opinion, that would be degraded and not be able to induce any kind of harmful effect. What about if you're trying to conceive? So assumed. No clear biological rationale at all of how this vaccine would affect fertility. So as I mentioned before, some women did get pregnant while in the vaccine trials, but I don't want to use that as any observational data arguing for and against, but really there is not a clear biological rationale how this vaccine could impact fertility. And again, I want to stress this, that the LNP-MRNA does not get into the nucleus of a cell, so it is not biologically plausible that it could alter the DNA of an egg or a sperm. So in summary, COVID mRNA vaccines appear to be generally safe for non-pregnant individuals. They were not studied in pregnant individuals. The risk of maternal vaccination to the fetus is largely unknown. If LNP-mRNA reaches the placenta and/or the fetus, there is a theoretical risk to the fetus associated with an immune response. What is very well known is that there's an increase with COVID-19 infection during pregnancy. And what we advocate for is risk assessment for each individual in discussion with their providers. I do, as many of you who might know me on this call, it is very frustrating to me and to my colleagues that we continue to guess about care for pregnant and lactating individuals. And they deserve better than that. And in that vein, I want to share with you two studies that we have rolled out in just the last few months. The first one is just approved. It is called SPIRIT, and we will be studying both pregnant and lactating individuals who elect to get the vaccine so that we actually can forward the knowledge and employ more informed counseling regarding the vaccine and its outcome. We also have the Predictive study, which looks at all pregnant women and what their immune response does to make them at more or less risk for acquiring COVID-19. So these studies are at Hopkins, Pennsylvania Hospital. They are the SPIRIT is in pregnant and lactating individuals, and Predictive is in pregnant. I'll put this in the chat. Many of you have already reached out to me to donate breast milk, which I so appreciate. These will be the contacts if you're interested in participating in the SPIRIT study. I thank you for your time, and again, I really apologize for the delay in us being able to start this presentation. I will look at the chat to see if I can answer any of your individual questions.
Thank you very much, Dr. Elovitz. We're going to now turn to Dr. Srinivas.
Good afternoon, everybody. Thanks, Dr. Howell, and thank you, Michal. As you laid out, when it comes to pregnancy, we know that the lack of information makes this decision very difficult, and I know we've had lots of conversations about the fact that pregnant and lactating women definitely deserve more than to be guessing. Interestingly, I think as a MFM specialist, maternal fetal medicine specialist, we're often, and not uncommonly, in the situation of having to discuss medications or therapies with limited information in pregnancy. And these conversations are guided and decisions are made after considering and discussing individual risks and benefits. And that's really what we're recommending regarding the vaccine. For pregnant patients, it's really not going to be a simple yes or no, but rather providing a framework for really how to think about this decision individually. And in many cases, any theoretic risk of the vaccine may be outweighed by the benefit. And while these conversations and being sort of in this situation of not having as much information as we would have liked, and while they feel so difficult, I do want to sort of take a minute to point out that we are still grateful to be having these conversations, as historically, pregnant and lactating patients are left out of the conversation altogether and are not really given the opportunity to consider their own individual risk assessment and approach. And with the advocacy of the Society for Maternal Fetal Medicine and the American College of OBGYN and other organizations advocating for pregnant patients to have this autonomy in considering their own exposure risk in making these decisions, we really have the opportunity to have these conversations individually. So overall, we think it's important that COVID-19 vaccines are not withheld from pregnant individuals who meet the criteria for vaccination. And so how do we really think about this and approach this when thinking about individual risks and decision making? The three buckets that we've sort of been talking about are those considering pregnancy, those who are currently pregnant, and those who are lactating. And as Dr. Elovitz talked about, if considering pregnancy or in the process of trying to get pregnant, we really recommend getting the vaccine before pregnancy. And there's lots of circulating things on social media about causing fertility issues. And as Dr. Elovitz just stated as well, there's not really a biologic basis to the vaccine causing infertility. And so if you're eligible, the ideal time would be to get it before you get pregnant. Similarly, if you're lactating, we think that there is not really a safety concern with the vaccine for lactating individuals or their newborns. So what I'm going to focus on really is in terms of pregnancy, with the limited information that we're operating on and some of the theoretic, potential for harm that Dr. Elovitz brought up, how do we approach that? We do know that from the CDC and well as from others that symptomatic pregnant patients with COVID-19 are at increased risk for more severe illness compared with their non-pregnant peers, given the caveats of some of the limitations of some of the information we have. Similar to other infections, we do know that pregnant patients with COVID-19 seem to have a slightly, while the absolute risk is low, a higher risk of ICU admissions, needing mechanical ventilation or respiratory support, and even mortality, as Dr. Elovitz pointed out as well. And pregnant patients that have comorbidities, such as diabetes or obesity, may be at even higher risk of some of these sequelae, consistent with the general population with these comorbidities. So it's for this reason that we really recommend having this individualized discussion with your prenatal provider about the vaccine that takes into account your personal risk of COVID exposure and illness. It's also important to remember that there's the immediate risks of COVID, but there's also some of the longer term sequelae that we're now seeing if you were infected with COVID, which obviously we don't even have information. We're gaining more information on that for the general population. Whether pregnancy affects that in some way, if you got COVID in pregnancy, that is definitely not known. But something else to consider is the sort of immediate illness effects in pregnancy and also long-term repercussions of being infected with COVID-19. So some of the things that we think about in this framework of what to consider when making your individual decisions is, your risk of COVID-19 illness. And so what kind of work exposures might you have? Volume of patients you're seeing, types of patients you're seeing, what home and community exposures do you have? So we're not living in sort of a small bubble per se. I mean, there's lots of other exposures that we have kind of in work and outside of work. So things like exposure from other family members, sick family members, as well as school exposures if we have kids, or daycare exposures, and then other personal comorbidities like obesity or diabetes or lung disease. As well as personal perspective and feelings about the risk of acquiring COVID and the immediate consequences as well as the long-term consequences. And that sort of framework needs to be then weighed against the theoretical risk to the fetus, as you heard from Dr. Elovitz. The fetal risk from mRNA vaccines is thought to be potentially low due to the expected degradation of mRNA. But as Dr. Elovitz pointed out, there are sort of a variety of different things that we still don't know about kind of the crossing into the placenta, whether that does elicit a fetal response or not. And so there's definitely many unknowns in this space, but all of those are theoretic harms potentially that need to be weighed against the sort of known harms of COVID illness in your particular situation. So individual risk assessment and decision-making needs to really balance these fetal risks with the risks associated with delayed vaccination and the possibility of maternal infection. So for example, someone who is pregnant, healthcare worker, but working largely from home with minimal other sort of home and community exposures may really consider waiting until post-delivery for vaccination. Whereas a different person who is pregnant, a healthcare worker working with a higher volume of patients, may also have higher home exposure risks such as school or daycare, maybe comorbidities. That person may strongly consider getting the vaccine given the risk of exposure and the risk of illness sort of outweighing the theoretic risk of the vaccine. So this really is an individualized decision. And we really encourage patients to have these individual conversations with their providers that take all of these important pieces of information into account to make a personal decision. Again, we know for pregnant patients in particular, it's not a simple yes to get vaccinated or no, do not get vaccinated, but having this framework. And between the two choices of being vaccinated versus getting COVID, women must make a choice that fits into their own values and the setting in which they work and live. And so we hope that framework will help many of you who are pregnant or considering this have a kind of a conversation that's particularly balancing your risks in all of those different areas. I'm now going to turn it over to Dr. Brennan, our CMO, for a few comments. And then after Dr. Brennan, Dr. Offer We'll hear from two healthcare workers who will discuss their personal considerations in decision making. Dr. Offer is an OBGYN in the Penn OBGYN Associates practice, and Jess Goetzinger is a nurse on labor and delivery at HUP. Thanks for the opportunity. We'll be happy to continue to answer many of your questions.
Thank you. Sindhu, can you hear me?
Yes.
Good. I'm relieved. I'm not going to show any slides. I only had one table that I wanted to show, but what I want to talk about just briefly is the status of our vaccine rollout in Penn Medicine. So we're making good progress, and we've been able to offer to date vaccine to almost our entire workforce, and we expect to cover the entire workforce by early next week. To date, we've offered slots for vaccination to more than 40,000 people, and we only have about 4,000 more to go. Of all those who have been offered the vaccine, 65% have scheduled. So we'd certainly like to be higher than that, but we're making good progress, and we have a sufficient supply to meet our current schedule, and we've already begun to receive second doses. But there's a big delta between where we are in terms of scheduling and administration and where we want to be. One of my concerns is that the vaccine will become more scarce in the coming weeks as the public health authorities begin to pivot to other sectors of the population that are really demanding vaccines. So essential workers, first responders, and the public in general really wants to receive this vaccine. The city is moving to the so-called 1B group of vaccinees. Those are the essential workers, probably around February 1st, and they may ask us to help them to administer it. But at that point, we may begin to see diminishing supplies. So I would encourage everyone who has made the decision or strongly considering the decision to respond to their email link and get scheduled. Our priorities right now are to finish offering the vaccine to the rest of our workforce, and then to increase the vaccination rate among persons of color. We are seeing a divergence and a disparity between whites and other demographic groups, other racial and ethnic groups in our vaccine efforts. While all of those demographics have improved between the first week and the third week of vaccination, there is a further divergence and a greater disparity developing. So at this point in time, about 70% of white staff members who've been offered the vaccine have scheduled. However, among non-Hispanic Black staff members, only about 30% have scheduled. So there's a 40% gap. That gap was 30% in the first week. Although both groups were higher and have shifted down, the gap is wider. So it's really important that we narrow that gap. And then we want to sweep in all of those who have deferred so far and may be left out or delayed as vaccine becomes less available. The general public will probably not receive the vaccine until after healthcare workers, staff and residents of long-term care facilities and essential workers are vaccinated. So we're probably looking at a March timeframe there. There are a few questions that were submitted, and one of those was, is the link for scheduling the vaccine still time dependent? That is not active after 10 days. So the link never inactivates. It's always been active. If you have your email, you can go back to it. That 10-day number that is being asked about is really the window for scheduling. So we had a 10-day window for scheduling, but it's 10 days every day. So if you don't schedule today and you go in tomorrow, you still have a 10-day window. We're stretching that out to 14 days, but the link is always there. Then there was a question about accommodations being made for pregnant women with regard to the timing of vaccination. So if you decide to defer vaccination to a later trimester or until after delivery, we'll certainly make every effort to vaccinate you at that time, dependent on the availability of vaccine. And as vaccine moves away from hospitals, it will move into practices and other venues where vaccine will be available. There are also some questions about the new variant strain B117 that has been identified in the UK and in 4 states so far in the United States. First, I would say that it's probably in many more places than we know. It's only been identified 4 times, but we don't do very much genomic sequencing, and so we really don't know the extent of it. But the fact that the people who have had it in the United States can't identify their contacts suggests that it's prevalent in the community. From what we know to date, it appears to be more easily transmissible, perhaps because it may bind more avidly to the ACE2 receptor that enables it to enter human cells, or it may just be related to social activity. So in terms of severity of illness, it does not appear to create more severe illness, and at the present time, there's no evidence to suggest that it will not be that the vaccine antibodies that are developed will not be active against it. Although that's a big concern, because the genetic sequence of mutations encodes for the spike protein that Michal was talking about earlier, and that spike protein is the binding area of the virus. So you can imagine that if further mutations occur, it could interfere with that target site for the spike is the target site for antibodies produced by the vaccine. But at this point, there's no evidence to suggest that that's the case. So Sindhu, I think I'll stop there and allow you to go on to other issues, and be happy to take questions at the end.
Thank you, PJ. I'll turn it over to Dr. Offer.
Sindju, I'm not sure if she's able to get on. We might want to go to our nurse first.
Hi, Jess. Would you like to go?
Sure. I think I got it. Can you hear me?
Yes.
Hi. I'm Jess Goetzinger. I'm a labor and delivery nurse here at HOP. And I decided to get vaccinated for a few reasons. The first is we are exposed to so many different patients on a daily basis, so I never know who I'm going to be taking care of, if they have the infection, if they're asymptomatic, if they're not. And I have a newborn, well, she's 6 months now, at home. So getting vaccinated for me was really a no-brainer. If I could protect myself and protect my baby, that's exactly what I'm going to do. I've done a lot of research on my own about how the vaccine works, and just having the antibodies in myself being transferred to her through my breast milk, just like, other illnesses. I just want to protect her. So that was my main concern. Not concern. That is why I did it. I have a son who goes to daycare, so I'm not really sure what he's being exposed to. They do wear masks, but you never know with toddlers. So if he's bringing something home and my 6-month-old is protected with my antibodies, again, I'm okay with that. And then I know we're not really sure if me being back or us getting vaccinated, we're not sure if we could potentially pass on the virus if we're exposed to it to other individuals, but my family is taking care of my children when myself and my husband are at work, because he's an essential worker as well. If there's a potential to protect them through my kids, again, they're high risk, over 65 with pre-existing conditions, diabetes, hypertension, all the ones that we're super concerned about, asthma. If we could potentially protect them, that's, again, it's a no-brainer for me. That's why I chose to get vaccinated.
Jess, thank you. There is a
You're breaking up.
Did you notice any symptoms in your 6-month-old after breastfeeding?
Not at all. And she's so healthy. no symptoms. I didn't have any symptoms. I just had pain at the injection site, so I didn't have symptoms, and I didn't notice there were no fevers. I checked her temperature every single day, and she was fine.
Great. Thank you so much. Dr. Offer, I see you're on now.
Okay, good. Can you still see me?
We can see you and hear you. That sounds better.
Okay. All right, very good. Hi, good afternoon. Dr. Howell, Dr. Srinivas, thank you for inviting me to speak. So as Dr. Srinivas said, I'm an OBGYN here at Penn OBGYN Associates, and I'm the medical director at Radnor Women's Health, and I am currently 31 weeks pregnant. I had got my invitation the other week, around 29 weeks, about getting the vaccine, and after much deliberation and pros and cons, similar to what we've heard about on how to approach deciding, I decided to get the vaccine. What went into my factors, I had read all the society statements. I spoke with colleagues about pros and cons, and then I had to weigh my risk factors. I am continuously face-to-face with patients in the office or the hospital. My husband is a pulmonary critical care attending, and he works in the COVID units. My kids are in school full-time, so I have lots of avenues where it could potentially come from. And it seemed like the known evil of COVID outweighed the unknown and possible theoretical risks of the vaccine. I guess I'm hanging my hat on that, like similar vaccines that are helpful during pregnancy, that this will work. We don't know that information, but kind of hoping on that. Similar to what other people said, the first shot I got, no real side effects except a sore arm. I do go tomorrow for my second vaccine, so we'll have to see how that goes. But I felt a sense of relief after getting the vaccine. I felt like there was some sort of hope. The other part of it was I knew I was pregnant. I hope if breastfeeding goes as planned, that could be another year plus of my life, and my potential risk for exposure wasn't going to get any better. So I felt this was the best choice for me and for my family to give it a shot.
Thank you so much, Dr. Offer. Thank you so much, Jess, for your telling us your decision making. It's been very helpful. What we'd like to turn to now, and we know we're running over, and many go back to your work or your other activities, but we thought we'd still take about 10 or 15 minutes to address some of the main questions that came up, additional questions. And I'm going to turn it over now to Dr. Pulit, who is the division chief for general OBGYN, and she's going to kind of guide us through the questions. We're also joined by, I mentioned already, Dr. Gracia from REI, as well as Dr. Srinivas and Dr. Elovitz. So go ahead, Dr. Pulit.
Thank you so much, Dr. Howell. And again, we want to apologize to you all for the technical difficulties. It sounds like the main question in the chat is how will this information be transmitted to those of you all who are unable to stay or weren't even able to get on in the beginning. And I would just suggest that the same way we sent out the information about the town hall, that we could send out a link to the recording and hopefully have it edited down without our stuff in the beginning. So that's what I would hope we could manage, please, Mike and Chris Clark, who are our IT folks on the other end. So first off, we accepted a large number of questions from you all. And so I tried to pare those down into ones that were already covered by Dr. Elovitz in her great presentation in the beginning and Dr. Srinivas. And we have a couple of follow-ups, understanding that we will not be able to touch on all of them. Dr. Gracia, I want to start with you, which is how would you advise a patient who is considering going through IVF, and would you suggest delaying the transfer until the patient receives the vaccine? Gracia, are you still on? Okay. Dr. Srinivas, I'm going to start with you. I think we've covered the concerns about receiving the vaccine if someone is breastfeeding. Did you have anything else you wanted to add to that?
No, I think Dr. Elovitz covered it a little bit as well, that overwhelmingly it seems like that there's enough information that it's very safe, like seems to be very safe, both for the pregnant or the patient that's lactating as well as the newborn.
Great. follow-up for you then, Dr. Srinivas. Can you discuss a little bit about the differences in the UK versus the United States recommendations for vaccine administrations and waiting times?
Sure, and I know this came up from a few different people because there's just vastly different approaches. And I think they're just different approaches based on the kind of the fact that we don't have much information. So we've reviewed a lot about sort of how to proceed with decision making and risk assessment for your individual risk sort of benefit balance, as Dr. Offer and Jess sort of talked about as well. And the UK's approach was just more of a, I think what honestly we saw sort of historically in the United States, which is that we leave pregnant and lactating women out of studies to begin with, so we don't have the information. And then when it comes to decision making, we just sort of don't allow them to make the decisions, but just say that they sort of can't have access. And so I think the approach is just a different philosophical approach. And I think the approach in the United States is more of a individualized approach that came from a lot of advocacy. And we're really, I think, very thrilled to be able to be taking the approach that we are versus the sort of more sort of dogmatic approach, even though the information is very limited.
Great. Dr. Srinivas, while I have you here before we move to Dr. Gracia, when we're discussing the second vaccine increasing the chance that someone has more side effects, specifically fever, can you discuss whether or not post-vaccine fever in and of itself is dangerous to the fetus?
I'm going to actually let Dr. Elovitz, you're still on too, right?
Yes.
Okay, I'll defer what Dr. Elovitz thinks about that, about fever. I mean, there's theoretic risks of a fever, and so I'll defer that question to her.
Brennan, repeat for me, what was the overall question with fever in general?
We know that the second vaccine has had some increased immune responses, fever being one of them. Is post-vaccine fever in and of itself a concern for a fetus?
So as I always try to balance, for those of you who know me, transparency versus, saying things that people take out of context. So I want to be very clear here. There is data about viruses and fever in general be associated with adverse neurodevelopment. In saying that, a lot of that work comes from animal models. The associative studies in humans is difficult to interpret. And we all know that many of us have been sick during pregnancy with fevers from all different other causes and our children, thankfully, are very fine. For the post-vaccine, the vaccines that we give now for flu and DPT in general don't induce a fever. I will also say that it hasn't been very well studied to know that there's any effect. We have not seen one observational. For fever from the COVID vaccine, remember, just to be very clear, we actually want that. The question is, does that harm our fetus? And in full transparency, we just don't know. It's in general seems to be, from the clinical trials report, a very transient response. So is that enough to cause harm? I can't say with any definitive thing that it does or it doesn't.
Thank you. Dr. Gracia, you're on now, correct?
Can I add one thing to that, actually? I just wanted to add, sort of dovetailing off of what Dr. Elovitz said, that so if you've decided to get vaccinated for the protective effects of the vaccine in your risk assessment, the theoretic, unknowns of a fever to you, I wouldn't defer the second vaccine for the 15% chance that you may get a fever and not take the full effectiveness of the vaccine that you've already started to get with getting the first shot, if that makes sense. So for people that are asking about the fever, I think some people are asking about it in the context of actually already having gotten the first shot. And so once you've started the vaccine, we recommend that decision-making continue and you complete the vaccine. And the risk of fever from the second shot is actually on the lower side of all the symptoms that are kind of reported.
And to be very clear, Rennie, if we can just make the comment, there's a lot of lay press out there right now, and not just lay press, about getting one shot. So I want to be very clear that the emergency use authorization was based on the clinical trials that had 2 shots. So while some people are trying to read the data and extrapolating that 1 shot is protective, we absolutely have no data on that. So as Dr. Srinivas said, if you're going to make the decision to get the vaccine, by all means, the benefit comes from 2 doses.
Dr. Elovitz, while we have you there, you posted something, and I want to make sure we deal with it, which is this issue of the trimesters. So can you just quickly say something about that? Because there are definitely a lot of questions about if you were going to get the vaccine in pregnancy, would you recommend a specific trimester?
So I would love to be able to give everyone this information. So in general, we usually avoid the first trimester because the fetal brain and the developing organs are so vulnerable, right? But we know from natural infection from viruses that if you get exposed in the first trimester, let's say with chickenpox, the outcomes are much worse for the fetus, for fetal development. Exposure in the third trimester, while it's not as bad, is more likely because there's increased placental passage. So we're balancing this risk of, is there more placental passage? And if placental passage causes harm, that's bad. But if there's even a little placental passage in the first trimester, there's more risk for harm. So without knowing if the LNP-MRNA crosses the placenta, we can't make that decision. So in your risk assessment, I would remove at this point trimester because there's not data to guide either way. So it really comes down to your overall risk, not the trimester. I would use it as a whole. Hopefully that makes sense.
Thank you. And you all, I'm going back and forth between the chat and the questions and answers in addition to the summary questions that we've already come up with based on the ones that we were sent. So first off, I asked Dr. Gracia, how would you advise a patient who's considering going through IVF? She typed her answer in the chat because she's unable to be heard anymore. So for those of you all who are on the chat, please make sure you check that. I don't want to spend the time going over that then because we can actually cover a couple of other things. So Dr. Elovitz or Dr. Srinivas, if a patient is considering pregnancy, when should they get the vaccine? And how long should they wait to conceive? Michal, I think you touched on this in your PowerPoint, but if someone asked you, how long should you wait, what would be your answer?
There's no data, so the vaccine outweigh any other risk. So right. I don't think I would not, and I think Clarissa and I agree on this, as everyone else does, there's no waiting period that we would recommend right now. I think the most important for a risk-benefit ratio is to get the vaccine if you're not pregnant, because it's much, you want to do it while you're not pregnant.
And we spoke about that, which is that there is data, there is information out there in the press about waiting, but that does not come from any specific studies, correct?
There is no biological plausibility for how this would affect fertility. And again, those who know me, I can come up with a lot of biological plausibility. I can't come up for a reason why this would affect fertility.
Thank you.
That's circulating from that UK statement. So when you asked about the differences, it's just an approach that they decided to take with no basis for that approach, like no data to suggest why that sort of window was recommended.
Is there a risk of preterm labor with the vaccine, either of you?
There's absolutely no data. Again, from the Moderna, there were about 30 to 35 pregnant women who got pregnant during it. Some of them actually weren't allowed to get the second shot and were removed from the trial. And again, with 30 women, there's just going to absolutely be no data.
And so why
it would happen.
One of the questions that's coming up, which I think is a really good one, is our answer to a lot of these is we don't have any data, right? Many of us who have gotten the vaccine have enrolled in the CDC VSafe, where the CDC texts us and asks us about our side effects. And the CDC is including in that group lactating women, correct? When do we expect to have some data?
So that is an excellent question, Rennie, and I appreciate that. And for all of you, thank you, Rennie, for bringing that up. So I have to tell you, I got my vaccine out in Chester, and I did not get the VSafe pamphlet. So if you happen to get the vaccine during the rollout in December and did not sign up, did not get the information for VSafe, please go in and sign up. So for pregnancy, there is a checkbox to put that you're pregnant. For lactating, I'm getting different information. I think there's a write-in spot. We can circulate with that, the recording, if there is. He's collecting it on pregnancy. Depending on the numbers getting vaccinated, I wouldn't expect outcome data for another 6 months. I will tell you, and I think Dr. Srinivas put in the text, there's a University of Washington registry for pregnant individuals. I mentioned the SPIRIT study, but to be, again, very honest and transparent, I don't think we'll have pregnancy outcome data. And just for immediate pregnancy, not neonatal, but just immediate pregnancy data for another 6 months at best.
Great. We've mentioned in the past that we are extrapolating a lot of information about COVID from prior vaccinations and from prior illnesses. Can we talk a little bit about the Ebola vaccination process, technology, saliva, and how that has guided our information about COVID-19 vaccines?
So the Ebola, the adenovirus, Rennie, is that what you're asking? The vaccine?
I think so. That's a question. Yes. I'm going to say
So-
yes for that.
A few of you, and I try to answer some of them, chat. The AstraZeneca vaccine that is coming out is an adenovirus vector to do the same kind of thing that we talked about, right? To send the message to fake, if you will, the body to start making the spike protein. That adenovirus is pretty similar to what was used for the Ebola vaccine. We know the Ebola vaccine was given to pregnant individuals. What those of us on presenting on this call talked about just the other day is I have two caveats for that. First of all, I haven't seen the safety and efficacy data from that. So while AstraZeneca is putting out that it's good, we need to see it first. That's number one, in just the general population. Number two, and I have not done this, but I will, is we need to revisit the safety data from the Ebola vaccine in pregnant individuals. So remember, it's always, as alluded to on this talk, it's always a risk benefit. So Ebola is absolutely deadly. So the onus to take that vaccine in pregnancy is even different, more different than COVID. So I have not looked at that data, but when the AstraZeneca goes through the FDA review, we will look at that as well and see if that perhaps has more data on it. I will give you the caveat that DART data, that reproductive toxicology data I talked about, doesn't routinely include placental passage, which is something we've talked to the FDA about. So again, I know you're all interested if there's a known safer vaccine. If we believe that is, we will obviously message that out. And then I will talk ahead about some of the nasal vaccinations. In theory, those also would prevent kind of this placental passage. So again, just more that we need to come out. A lot of new science, a lot of new technology, and we promise to all of you we will be on top of this and share the information as in transparent fashion as we can when it comes out.
Speaking about the vaccines and pregnancy, since we have more data about one versus the other, when pregnant patients are electing to get the vaccine, is there a recommendation that they request one over the other? And then if so, is that even possible to request one over the other at Penn?
For the Moderna and the Pfizer, Rennie, is that what you're asking?
Mm-hmm.
So Moderna and Pfizer, here guys, is really virtually the same vaccine, right? There is no reason to think about how they are designed that it would be different. So I would, and again, despite what's being said in the lay press, whichever vaccine you're allocated to, I have absolutely no preference or bias. I would have taken either of them. I wouldn't tell a pregnant patient if they decide to get the vaccine that either is different. But what I would say is get the same one for both doses. So I do not think there is a difference between Pfizer and Moderna as far as risk or benefit for pregnant women.
And so if someone deferred now and then ended up getting one of the other vaccines in the future, like the AstraZeneca, would you have a recommendation about Pfizer and Moderna versus AstraZeneca?
Have to see the AstraZeneca data. Right now, I can't make any recommendation on AstraZeneca without actually seeing their safety profile and reviewing the original Ebola trial.
Great. And so a lot of people are asking about AstraZeneca in this other chat. And so the answer would be, at least at this point, it sounds like we know more about the Pfizer and Moderna vaccine. So if you were pregnant, getting one of those seems like the better option.
Yes, agree.
I think I'll take this last question, which is how long does it take for the antibodies to develop and pass through the breast milk after one receives the vaccine?
You guys are asking tough questions. So first of all, let me just say, I glanced down at my email and there's about 50 emails from all of you saying you want to be part of the SPIRIT trial, and you just kind of warmed my heart. So thank you for that. So let me back up and say, we know that when we're breastfeeding, right, our antibodies cross into the breast milk and go to the fetus. And we know that's one of the reasons why the American Academy of Pediatrics and ACOG and everyone else recommends breastfeeding is those initial few months, our antibodies are able to cross to our baby and give protection. Now, that is based on older studies. The COVID vaccine and the antibodies it produces a polyclonal antibody in our system. So you would think all of that gets passed on. The one caveat I'm going to have to give you with all this is we haven't studied it. So antibody dynamics and crossing, we need more data on in regards to this vaccine. So one of those studies I alluded to that's just been published, so that with natural infection, so natural COVID infection, not vaccine, the antibodies produced in the mom, right, that in theory should cross that placenta, didn't cross with the same efficacy that we've seen other antibodies crossing. Now that's natural, not the vaccine. My point really is that we don't have the antibody dynamics from placental or from breast milk for me to definitively say one way or the other how long they would last or not.
Great. You all, there are a number of questions in the chat that I really do believe are based on the individual assessment that Dr. Srinivas talked about earlier, where some of these are, I need you all to call your primary OBGYN or your primary infertility doctor and have some specific conversations about what your concerns are. I want to thank everybody for their participation. Obviously, this was a huge topic and really very well received. And thank you very much to our panelists for sharing their wealth of information. Dr. Howell, I'm going to turn this back over to you.
Great. So I just want to echo that gratitude to these panelists and all our faculty members for participating. I know we had a huge turnout. Thank you very much for your participation.